And what we do is we place the wedge and the sectional matrix in, because these give you fantastic contacts after they're done. And what we have here is a cleaned out area that we've used some surface conditioner, something like you can use just regular chlorhexidine or chlorhexidine soap to remove any of the bacteria out from the tooth structure. Now, in this case here, I am not going to pre-treat the dentin with any sort of acid conditioner. One of the reasons why is I don't want to stimulate up that nerve any more than we already have. Plus, with Truth Glass Ionomer, you don't need to do it. Now, in this case here, I am using the Fuji Triage White. It comes in two colors. There's a white and a pink. We actually use the pink for sealants, so we can see where it is. In this case here, in restorative materials, we utilize the white. And it's a little soupy when it comes out. And while I have a quartz tungsten halogen light here, the only thing this light is doing is providing heat. Now, heat on true glass ionomers will accelerate the rate of set, but the light itself will not cause the material to set. Again, true glass ionomers will not set under a light. And you'll notice here also I kept it off the enamel margin. Okay. Then I utilized an A2 shade of Fuji 9 Extra. Now, the reason why I use the Fuji 9 here is because it's more of a packable material. So we'll go ahead and flow this material in. And I also like it because it's unit dose. You activate the capsule, you triturate it, and then you dispense it right into the cavity itself. And this is what you've got. Now, at this point, most people would just go ahead and form it and smooth it off. You know, I do enjoy dentistry. It is a passion. And so one of the things I like to do is try to make teeth look like teeth, resemble teeth. So what do? I try to use some tints and opacers, try to create a central groove and put a little bit of color into it. And then, after the material is set, because it will auto-cure, I remove out the sectional matrix and the ring itself, and then use a little bit of G-Coat Plus. And one of the reasons why I like G-Coat is it will coat both glass ionomers, comprimers, resin-modified glass ionomers, true glass ionomers, and light cure it. It flows into all the nooks and crannies that are formed after you adjust the occlusion and polish it. I just wanted to point it out to you right now. The great thing about true glass ionomers also is after you remove the rubber dam off the teeth and you start adjusting the occlusion, saliva has the remarkable effect of strengthening the glass ionomer material itself. And so afterwards, after we adjust the occlusion and we check the occlusion with articulating paper, then we'll go ahead and apply G-Coat and light cure it. Now, at the end of this restoration, what I want to point out to you is a couple things. Most people would say, why don't you just use a composite? Well, the one advantage, again, that we have is we've got fluoride release. Not only do we have fluoride release in a high karyostatic person, but we also have fluoride bathing the adjacent tooth. And it can be recharged by fluoride treatments, by varnishes, by fluoridated washes. Anything that has fluoride can recharge. It's almost like a battery. Now, here's the other advantage to this material. Most people utilize these as bases. Let's say this girl leaves your practice and she comes back 3 years later. We all know that the glass ionomer is not going to wear as well as composite does. Let's say you have some marginal ridge chipping, or let's say the cavo surface margin is chipped, or you have some just occlusal wear, which can happen. If she has no signs or symptoms and the tooth next to it's in great shape, you treat it like an enamel restoration. Prep the tooth. In fact, you probably don't even have to anesthetize it. You can prep 1 to 2 millimeters, acid etch it, put an adhesive resin on top of it, put composite, polish it, and you're good to go. So I think this, in this situation, in this very specific clinical situation, is probably the material of choice that we utilize in our practice. Now let's talk about resin-modified glass ionomers. Resin-modified obviously means resins within the glass ionomer. Now, resin-modified glass ionomers, the two main types that we utilize are either restorative materials or liners bases. The types that we have in our practice are Fuji 2LC, Fuji Filling LC, and Keytac Nano as restorative materials themselves. We'll talk about that. Now, most people, when they talk about resin-modified glass ionomers, we talk about the sandwich technique, which we've heard in Class 2 composite restorations. Most people, when I hear sandwich technique, I think of Gino's cheesesteaks from Philly. I like Gino's rather than Pat's because Gino is actually using provolone cheese rather than Cheese Whiz. That was supposed to be funny. Okay. So now, when most people talk about sandwich technique, we talk about a class 2 restoration and whether there's an enamel rim or not. If there's an enamel rim, you can utilize a resin-modified glass right on top of the dentin. If there's not, that's where you would use true glass ionomer down to maybe the dentin enamel junction or the dentin cementum junction. The two types of liners that we utilize in our practice come from 3M and from GC. One is the Vitribond Plus, the other is the Fuji Lining LC. The differences between the two materials, one is just a flow. One has more flow than the other. And honestly, one has more resin in it, one has more glass ionomer in it, which also means one is going to set harder and quicker than the other one does. It's been my experience that the 3M material sets harder and quicker. It has more resin in it. The Fuji Lining LC has more glass ionomer in it, so it doesn't feel quite as hard after you cure it. But they're both workable, they're both radio-opaque, they both release fluoride, they have both low modulus and low microleakage. And where are we going to use some of these materials? Well, one of them is in enamel defects, and we all see this, and I just took a couple of pictures, people coming through my hygiene, and I've noticed all of these enamel defects, and most of the time we leave them alone. The only problem is when we get in there with our pick, or explorer, as John said this morning, and we get into some of these areas that are a combination of both enamel, dentin, and cementum. What do we use here? What's the best restorative material in an environment where we really can't isolate all that well? Okay, well, let's take a look. One of the cases I'm going to show you with Fuji Filling LC. Again, it's a resin-modified glass ionomer. It has different colors to it, and it has its own self-conditioner in it. Their self-conditioner, interestingly enough, is based off of the backbone of their G-bond, which is their 7th generation all-in-one bonding material, adhesive material. Let's take a look at this case. This patient comes in, says he constantly takes his finger up here because he feels something on the front of his tooth. And of course, our answer to that would be, your finger doesn't belong in your mouth, right? Okay. But he says, it bothers me. And I take my Explorer, and while the enamel is hard, the dentin is beginning to get soft, and it is underneath the gingival margin. So what are we going to do here? Well, in this case, what we decided to do is use a resin-modified glass ionomer. Because the fact is, I'm not worried about the enamel. I'm worried about the dentin and possibly cementum that we really can't even see. So what do? I anesthetize the patient. I place a 00 cord that's been soaked in Hemodent, and you can see how the tissue is slightly blanched. And then what I do is I just take a very coarse diamond and I just roughen up kind of irregularly all over the enamel itself. Rinse that off, and then I'll use their self-conditioner all over the tooth itself and the enamel on the dentum and try to jam it up underneath without disturbing the tissue too much to try to get as much of that self-etching primer subgingivally. Then I'll use the air, and I will go ahead and evaporate all the carriers and the solvents. And this is what it looks like. And in this case here, since I'm using the Fuji Filling LC, you hand mix it, put it into a Centrix tip, and then syringe it. Now, again, one of the disadvantages with glass ionomers and resin-modified glass ionomers is handling. Unlike composite materials, which are like cured that we utilize, which come in a very easy-to-use gun and unit doses and tips, it's not that way when it comes to glass ionomers. You have to hand mix these. And then, of course, the delivery system has always been the issue. And I think maybe that's one of the drawbacks to using these materials. I find that one of these metal cannulas from Centrix will help me deposit the material exactly where I need it. And then you go ahead and place it and manipulate it and use your composite instruments to move it around. And then this material, because it has resin in it, you cure it. Most important cure is not the facial cure, it's the incisal cure. You want to bathe the entire tooth. I cure each surface with a high-powered now they're all high-powered, the LED lights, 10 seconds on each surface. And this is what we wind up with. Now we have to finish and polish these. Now, one of the tips and tricks that I've learned from some of my friends who are sitting in the back of the room is you'll notice in youthful enamel the amount of pericomata or surface texture. And the problem we always have is that when we polish these to a high shine, polishing sometimes removes that surface texture. And to us as dentists, we love the surface texture. Of course, it can't be too rough, otherwise the patient takes their tongue and says something feels rough. So what do we use here? I use a 5856 from Brasseler, and on dry, very low speed, I kind of move it around in ovals. And by doing this, I'm removing off all the flash and yet leaving surface texture all over the restoration. And then I use something called a groovy diamond from Clinician's Choice. And what's interesting about this tip is that when you ever rub it all over the tooth, the first 10 or 15 seconds, it doesn't look like it's doing much. And then 20 or 25 seconds in, all of a sudden, bam, it starts to just shine and shine and shine and shine. And this is what we wind up with after we remove the cord, surface polish. Now, the great thing about Fuji filling is it has a higher resin content. More resin is more composite-like. More composite-like, I can get a better shine on it. And so I'm able to do these very simple, very cost-effective restorations in my general practice. I know Sandy was very kind about talking about my practice. The fact is we have a large general practice, and the majority of my dentistry is general dentistry. And while I love doing all the smile design concepts and full mouths and implants, I have no problem doing single unit restorations every single day. As long as you have the systems in place like John spoke about this morning, this type of dentistry to me is just as enjoyable and profitable as anything else I do. I want to thank the Seattle Study Club for having me. If you ever want to get in touch with me, you can email me at drritter@mac.com or my website at ritterandramsey.com. Look forward to spending a couple of days here. Enjoy the rest of your time. Thank you very much.
I'm very, very happy to introduce someone who's really part of our Seattle Study Club family. Dr. Ray Kubik